Tonight, we begin with a story that feels both tragically familiar and urgently new. Deep in the heart of Africa, a nightmare is reawakening. In the Democratic Republic of the Congo's Kasai province, an Ebola outbreak is spiraling, seemingly overnight. Just last week, health officials were tracking a handful of suspected cases. Today, that number has more than doubled. We are now looking at over 150 suspected infections spreading across 3 new districts. The numbers are not just statistics. They represent families, communities, and a nation bracing for a potential catastrophe. The human cost is already mounting and is profoundly stark. More than 20 people have lost their lives. These are not anonymous figures. They are mothers, fathers, children. Tragically, among the dead are at least 5 healthcare workers. These are the very people who run toward the danger, the first line of defense against this unforgiving virus. Their deaths are a devastating blow, not only to their families but to the entire response effort, creating fear and depleting already strained teams. The outbreak, once confined to Ebola, has breached its borders, creeping into Chikapa and Kananga, raising the stakes significantly. These are bustling hubs of commerce and life. In crowded streets and markets, explosive transmission becomes a terrifying reality. As we stand here today, September 13, 2025, the world is once again watching the DRC and asking, are we ready? To understand the fear gripping the Kasai province, we first need to understand the enemy they are facing. What is Ebola? Simply put, it is a severe and often fatal illness in humans. The virus is named after the Ebola River in the DRC, first identified in 1976. It is a member of the filovirus family, known for causing hemorrhagic fevers. Its lethality is shocking. Case fatality rates have ranged from 25% to 90%. Misinformation here can be deadly. Ebola is not airborne like the flu or COVID-19. It does not travel through the air. It spreads through direct physical contact with bodily fluids, blood, sweat, saliva, vomit, feces, and via contaminated objects like bedding and needles. This puts healthcare workers and caregiving family members at high risk. Funeral and burial rites can become transmission vectors. Initial symptoms can be deceptive, often like a bad flu. Fever, intense fatigue, muscle pain, headache, sore throat, frequently mistaken for malaria. As disease progresses, severe vomiting, diarrhea, rash, kidney and liver function can be impaired. Some patients experience internal or external bleeding. It is a harrowing illness for patients and families. Understanding this progression underscores the urgency of the response. To truly grasp the situation, we must listen to the people living through it. In Chikapa, a diamond trading hub now under the shadow of Ebola, the usual hustle has been replaced by quiet anxiety.
Every cough you hear in the street makes your heart stop.
We are told not to shake hands, not to embrace. How do you live like that? Our entire culture is built on community, on closeness. Now, our own traditions feel dangerous. We wash our hands constantly, but we fear it is not enough. We pray for our children. The fear is not just of the virus itself, but of the economic paralysis it creates. With towns under lockdown, livelihoods are evaporating.
My truck is full of cassava that will spoil if I cannot deliver it. My family in Kinshasa depends on the money I send.
Ebola will kill you, yes, but hunger can also kill you. We are caught between 2 terrible fates. Officials are trying, but we need food, we need to work. This is a crisis that attacks us from all sides. Our teams are stretched. We are doing contact tracing, but people are scared. They hide their sick. They fear the treatment centers, places where you go to die. In response to the escalating crisis, authorities moved swiftly. The towns of Ilebo and Chikapa are now under strict lockdown. No one in or out without authorization. Checkpoints on all major roads, staffed by police and military. At the barriers, everyone is temperature screened. Anyone with a fever is immediately isolated and questioned about recent contacts, severing chains of transmission. Within containment zones, public gatherings banned, markets, schools, places of worship shuttered. Teams move through neighborhoods with megaphones distributing soap and chlorine, building a fortress of hygiene household by household. It is a massive undertaking, street by street, village by village. Ebola treatment units are rapidly constructed, isolated facilities where patients can be cared for safely. Inside, clinicians don full PPE despite the heat. They hydrate and manage symptoms, critical for survival. Each recovery is a victory. Beyond treatment, contact tracing is crucial. Identify contacts, monitor for 21 days, isolate and test if fever develops. Ring fencing builds a firewall around the virus. Even under the best of circumstances, containment is hard. In Kasai, officials fight on two fronts: instability and scarcity. Insecurity complicates response. Remote villages go unreached. Convoys require armed escorts, slowing vital supplies. The DRC's health system is chronically underfunded. Many clinics have a few beds, unreliable electricity, and shortages of basic supplies. Before Ebola, they struggled with malaria and measles. Now, they're the epicenter of a global health emergency. They need everything: more PPE, more beds, more lab capacity, more trained personnel willing to work in high-risk settings. Conflict breeds mistrust, rumors, attacks on treatment centers, and staff in past outbreaks, making safe burials and isolation harder. Logistics are staggering. Unpaved roads turn to mud. Reaching villages can take days by 4x4, motorcycle, or on foot. Getting a blood sample to a lab becomes a race against time. Delays endanger patients and allow silent spread before confirmation. In this landscape, geography itself has become an ally of the virus. The DRC is no stranger to Ebola. This is the 16th recorded outbreak since discovery nearly 5 decades ago. There is deep local expertise: doctors, nurses, epidemiologists, hard-won lessons enabling faster responses. Yet, rapid spread into larger centers like Chikapa and Kananga recalls West Africa 2014-2016, when urban routes fueled exponential transmission. That epidemic infected over 28,000 and claimed more than 11,000 lives. A catastrophe today's responders strive to avert. The 2018-2020 outbreak in North Kivu and Ituri, nearly 3,500 cases and almost 2,300 deaths, unfolded amid conflict, similar to Kasai's concerns now. A key difference: immediate vaccine deployment aided containment then. In Kasai, vaccination is just ramping up. The race is on. Uganda 2022 faced Sudan strain, no proven vaccine, relying on classic measures: contact tracing, isolation, supportive care. Kasai's Zaire strain is deadlier but has effective tools. Experience provides a playbook. The question is whether it can be executed fast enough under Kasai's difficult conditions. While the situation is dire, there is reason for hope. We now have an arsenal of medical tools to fight back. The most important is the Ervebo vaccine, highly effective against the Zaire strain, deployed via ring vaccination, contacts, then contacts of contacts, creating a buffer of immunity. Frontline workers are prioritized: doctors, nurses, burial teams, lab technicians, protecting the response itself. Care once meant only hydration and symptom management. Now antibody drugs, in Mazeb and Ibanga, significantly increase survival when given early. Administered early, these treatments can reduce mortality to below 10%, a monumental shift. An Ebola diagnosis is no longer a probable death sentence. Vaccines demand an ultra-cold chain in a region with unreliable power and tough roads. Therapeutics are costly and require IV administration. Success hinges on public health systems. Identify early, earn enough trust for ETU care, ensure supplies and staff are ready. Science gave us weapons. Now the battle is logistics and trust. The alarming numbers have put global health on high alert. The WHO leads the response with the DRC's Ministry of Health. Deployed, epidemiologists, logistics specialists, and clinical experts from prior Ebola battles. Governments are stepping up. The CDC and USAID pledging support, with the CDC's Kinshasa office engaging long-standing partners. MSF and others mobilize chartered flights, sending PPE, materials for treatment centers, water purification systems, and vaccine cold chain equipment. For the US and Europe, the risk remains very low. Ebola requires direct contact with bodily fluids, harder to transmit globally. Out of caution, the CDC has issued a travel alert advising enhanced precautions. Hubs may add screening and health declarations. These are safety nets, to be prepared, not to panic. The lessons from 2014 have been learned. Preparedness and rapid support can keep local outbreaks from becoming regional catastrophes. It can be easy to see a distant outbreak as someone else's tragedy. But in an interconnected world, a threat to health anywhere is a threat everywhere. A virus recognizes only opportunities to spread. Allowing Ebola to gain a foothold in Kasai risks the DRC and the global community. People in Kasai face disease, poverty, insecurity, and a fragile health system. Supporting the response, funding aid, providing expertise, ensuring vaccines and treatments is a moral imperative. Invest early, Containing small outbreaks costs a fraction of fighting large epidemics. West Africa's crisis cost billions and erased years of progress. The best defense isn't rushing aid after the fact, it's building resilient, well-funded, well-staffed local health systems that detect and contain threats fast. Congolese health workers are doing everything they can. Our job is to ensure they have the tools, the support, and the strong system to win this fight and prevent the next.